My name is Raj Pyne. I'm one of the interventional radiologists. I want to thank everybody for coming. Again, as I said before, can everybody hear me? Okay. Yeah. Again, thank you for coming because, again, as I said before, patient education and being proactive is the most important thing. So knowing your options is great. And again, I thank you for coming and being here with us. Again, I have the pleasure and the privilege of working with Dr. Eddinghausen and Dr. Haynes, who were fantastic. We all work very closely. I sort of wanted to tie into a lot of you'll hear a lot of the same themes, but I'm going to talk more about what we do as interventional radiologists. I think a lot of people do know a little bit of background about what surgeons do and a little bit about what radiation oncologists do. A lot of people generally don't know what the interventional radiologists do, so I'm going to describe a little bit about what we do. First, I'm going to sort of answer this question is something that sort of bothered me because it's always a question that a lot of people don't ask is how exactly does cancer kill people? It's something that, as most people have, I had a very personal experience with cancer. My grandmother was diagnosed when I was in high school. And I remember still thinking back then, when she was going through everything is what exactly it was that caused her to die. And, to this day, it's, something that, I was wondering in med school and you actually understand the more you see this. So the big question here is what it actually is that causes cancer to kill people. As Dr. Haynes explained a little bit about the way cells divide, the main thing about cancer is that it's just uncontrollable growth by cells, and they can't really turn it off. For most places, that doesn't cause the problem. In some places like the brain and the heart, it could cause problems because of space. But usually the main issue with cancer is that it spreads. Somehow it gets into the bloodstream and it goes to a lot of organs. Once that proverbial horse out of the barn, that's the real problem. And once it gets into major organs like the liver, which is what we're talking about here, it can cause some severe damage, and as the liver detoxifies a lot of the blood and does a lot of functions of the body. So to sort of explain this better, I'm going to use a little analogy here. I don't know if this rings home with anybody, but this is what termite damage looks like. So if you're looking at this, it's termite damage, and here's little termites look, and this is what they do to wood. So anytime you have a problem, as you would at home, you have to start thinking what your treatment options are. So what would be your treatment options if you thought you had termites in your house? Well, it's as with everything else, there's the basic options, the direct options, and there's the more creative options. So obviously the first thing most people would think about if I had to treat a termite would be I'd probably want to give some type of poison, or I guess it's called a termiticide, to try to kill the termites themselves. Every time you think of a solution, generally, you get some type of problem or what we call complication. So if you're going to inject the poison, the next thing you probably think about is, my worry is it going to get in my food? Is it going to get on, is somehow the kids or pets going to ingest it? You got to worry about poisons obviously in the body, in the house here. Next thing you do is fumigate the house, which I've actually never seen, but apparently it's a giant tent goes over the house and they seal it off and you can fumigate the entire thing. But again, you're worried about damage to other normal structures. If you just saw that the termites were in one main beam in the basement or on the porch, you might consider just removing that one piece of wood, cutting your losses and just removing that part. Or you might think of things like this new baiting system that a lot of insects and rodents people do. They put a little bait system. One of the little termites brings it back to the queen of the colony, and they actually go in there directly, and that actually starts killing it from the source. So why am I bringing up termites? It's a odd thing, but obviously there's an analogy here, and I think it's very similar to things like liver treatment. You have things like chemotherapy. Chemotherapy has been around for a long time. And all it is it's a toxic drug, and it generally, for the most part, most of them, what they do is they stop or hinder cell growth. Because your cancer cells are dividing very fast, they more preferentially kill cancer cells. But obviously you know that they also hurt the body in other ways. That's why people lose their hair, feel nauseous, and have all these other side effects. So that's sort of similar to the poison you can give. Again, this analogy is not very good, but with the radiation and fumigation, again, as Dr. Haynes explained very, very eloquently, you could radiate the entire part of the tumor, and they've gotten very good at that. Again, they've gotten pretty good at minimizing damage, and that was the big issue beforehand, but now they actually do it quite well, and just to direct it towards the tumor. Surgical resection, as Dr. Eddinghausen spoke about, is what we call the gold standard. If you are able to get the tumor out, if it's limited, there's not too much, and again, I know I'm reiterating a lot of what was said before, you want to take the entire tumor out because that is the gold standard. That is what you want to do because it's 100% cure. And so that's why, if at all possible, if we see anything and we know that Dr. Eddinghausen can take it out, the preferential ways to take it out. Then you have the other options of, literally when there are too many lesions to just take out, there's multiple spots in the liver, as some people say. Then you could do more what we do in interventional radiology, which is these liver-directed therapies, or what's called local regional therapies. So again, these things called ablation, chemoembolization, and Y90 are the words you're going to hear. I'm just going to explain those in just a second here. The main thing, again, that we're always trying to push, and this should be for most hospitals that are not doing it, this is the new method of everything for cancer. It should be multidisciplinary approach. You know your own field very well, because that's what you do. I don't know Dr. Haynes as well, and I don't know Dr. Eddinghausen, which is why when you're doing this, generally you see a medical oncologist first, and then this multidisciplinary approach of patients talking about the patient with multiple doctors from multiple approaches and figuring out the best tailored approach to that patient. That's the key for patients these days. We do this at something called tumor board. We see patients at a conference, generally discuss the patient and discuss which option would be best for the patient. So I'm just going to talk to you a little about, again, a lot of people don't know about interventional radiologists. What we do, we are radiologists. We have special training in minimally invasive image-guided procedures. And I'm just going to talk to a little bit about some of the things we do. One of them is actually, before we even do any procedures, it's called biopsies, and image-guided biopsies. These are just to make, a lot of people get very scared because they don't know when they come see us what exactly is happening, so I just try to explain this very quickly. To actually find out what type of tumor it is that you have, so that, like, as Dr. Eddinghausen said, you could treat it properly, you need to know what it is. The best way to actually do that is to take a little piece of that tissue and actually send it to the pathologist who looks under a microscope and deems, and actually does a lot of tests to say exactly what it is. And so when we do that, we do image-guided biopsies. Back in the day, a lot of this would require surgery or something more invasive. Now we can use CAT scan or ultrasound or X-ray or MRI and just take these little pieces very quickly. People go home half an hour later. It's fairly easy to do. It has its risks, but much better than what was previously done. I don't know if this is projecting well at all. Hopefully it is. So here's a picture of a CAT scan. And again, this is the liver here. All the white is bone, is the ribs and the spine. And again, you can see that there is a lesion here. Not seen well at this time, but on a previous CAT scan, it was known to, what we see is when it enhances, which means it takes the contrast up, it looks very suspicious for a tumor. So at this point, what we do, we just, we mark the spot on the side. We know exactly where to go. We know what to avoid. Here's a needle going in. We take a quick biopsy. This whole process takes about 10 minutes and we're done. This requires just a little bit of medication and a little bit of lidocaine, and we can generally get a pretty good biopsy so that people know where to go. So this is just the biopsy thing. This is a patient with lung. You can tell little nodules all through the lung and a bigger mass here. This is the aorta, the big vessel. This is your trachea. And you can see around here, there's a big mass there. This is us putting a needle in there and taking a biopsy. So we can do this for most parts of the body, quite easily. A much bigger liver mass. Here's a needle, and here's one actually in the rib. These are a lot more difficult, but again, we can put these biopsy probes in and get good parts of tissue. So that's just what biopsies are. That's how we get the diagnosis. Now let's talk about a little bit about treatment. The first thing we're going to do is talk about chemoembolization, and the other words you might hear are TACE, or transarterial chemoembolization. They're all the same thing. All this means, very basically, is that what chemotherapy is injecting the toxic drug into the veins all throughout the body, and seeing that it preferentially gets taken up in the cancer cells, but it will affect other parts of the body. What we're trying to do here is just to be more specific in delivering the dose right into the tumor. So how do we do that? Actually, the first question is, how can we do that? Most patients, when we see them in consult, their question is, if the liver is so important and liver spread is a big reason why people die, how can you just shut off the blood supply or inject chemotherapy? So in this case, just this is a diagram of the liver. Here is the tumor itself. The good thing about the liver, and this is actually what we use against the tumor itself, is that the liver is supplied by two forms of blood vessels. One is called the portal vein. This big blue vein called the portal vein supplies 75% of the blood supply and the oxygenation to the liver. The second is these little liver arteries called the hepatic arteries, which supply 25% to the liver. The good news is that tumors almost all feed off these hepatic arteries. So we could take that little blood supply that goes to the tumor, kill it, and still have all this portal vein supplying normal blood. And that's what we use to do these procedures. So chemoembolization has been done for about 20-25 years. It's evolved a lot over the time. Here's a case we did, and this is a patient with neuroendocrine tumor. You can see again, this is a axial view, or a shot right as if you're cutting like a loaf of bread, like Dr. Haynes said. This is a coronal view, as if you're cutting right through the front of the patient. And you can see this is normal liver. All of this is tumor. And that's tumor that's taking up quite well, as you can see, it's enhancing, what we're describing, enhancing. So neuroendocrine is very classic for having big enhancing tumor, but at the same time it causes a lot of symptoms too. It causes a lot of diarrhea and flushing, another problem. So what we do also here is also try to control some of these symptoms. So this patient, this is a patient who presented for chemoembolization a few years ago. This is what we do, is what's called an angiogram. For most people know, the cardiologist will go into the body and put a little catheter or tube into the heart and do things and put stents and things like that. As interventional radiologists, we do the same thing for the entire rest of the body. So here we are in the aorta, which is the big vessel, and then we're injecting what's called the celiac artery, which leads to the liver. So here's the liver. If I can outline, the liver's here. You can't see it because it doesn't show up on X-ray. And then right here is the tumor. You can see that. And you can see how much of the blood supply is going right to this tumor. And that's from those liver arteries, not those portal. Here's another little tumor there too. So this is a little bit later, about 10 seconds later. You can see that all that contrast is sucked up by that tumor. The tumor again, it's growing so fast, it sucks up the blood supply. And I use a weird analogy, but it's sort of like, it's in a growth spurt, so it's like a teenager. It constantly needs nutrition. So it's taking that up, and this here, it's actually staining. So it's actually keeping and hogging that blood supply or the contrast into the tumor. And that's what we use also against it. I'll show you that in a second. And here is a picture afterwards of doing the chemoembolization. So this point we did is we put a little catheter all the way down here. I'll show you here. The catheter went all the way into there. We injected chemotherapy along with little beads. So what we did is now there's chemotherapy stuck in the tumor, and then we shut the blood supply off. Now you can see here's another picture. That's where the tumor was. You can see there's no blood supply going to it because we actually injected little particles. They look like little sand particles, and they actually stop the blood supply going there. These are what these particles look like. Again, it's a little diagram showing particles going in and going towards the tumor. And 20 years ago, 15 years ago, we used to use much bigger particles, 500, 700 micron particles. Now we know that the particles need to be even smaller, because if you lodged everything up here, everything would get around. So now we actually get to the point where we know we want to be right in the tumor here, in what's called the peritumor capillary vessels, and we know that we want to be around 50 or 100 microns, so it's pretty small. The reason we started figuring this out too is also that a few years ago people started realizing, even though you think in theory it's a great idea to take these tumors and actually strip them of their blood supply, what happens when you actually do that? The tumors actually respond very well. They're very good at living without blood supply, so they very quickly send out all these hormones that say, I need to grow, I need to recruit more blood vessels because I have no blood vessels, and so a lot of them actually grow quite well in that situation. So we've realized that sometimes embolizing in that way isn't the best thing. So this is just the embolization and how we used to do it. The newer particles too, when we use are called drug-eluting beads. I don't know if anybody's heard of that. All that means is that instead of dumping chemotherapy in there, now the chemotherapy is attached to these little particles that we inject in there, and they're slowly released over 2 weeks so that you don't get a big rush. The good news, why that helps so much, is that you don't just get the big side effects from most chemotherapy. Here you get minimal side effects. So a lot of people will ask, will I get the hair loss? Will I get a lot of this? Not much. However, you do get something called post-embolization syndrome. What that means is, the best way to think about it, it's sort of like a nasty flu that lasts for about 24 hours. So these patients, with the chemoembolization, we generally admit them overnight. They have some belly pain, nausea, vomiting, they have a little tough time eating, but usually by the next day they're pretty good to go home. So that's sort of the little side effect and the downside of the chemoembolization. Just the last little diagram showing little particles going forward into the cancerous tumor and hopefully getting this to go down. So again, we could use this for a lot of tumors. As Dr. Haynes was saying, they use the radiation for smaller, limited amount of tumors. If you have a lot of tumors, we can use this. It's not a cure, and this for most patients, or obviously for almost everybody, it's not a cure. It's palliation, which means we're trying to control the growth of these tumors, trying to make them smaller, trying to make the amount of tumor go down, make people's lives better, and hopefully allow them to live a little longer. That's what the purpose of this is. Tumor ablation. Dr. Eddinghausen also touched on this. Again, we work very closely. I've been in the OR with him when he's doing this. If I can lend a hand to him. Sometimes we do these also what's called percutaneously, which means through the skin. So just like he was showing you some of the ablations they do, here's some of the ablation types we do in the interventional radiology using usually CAT scan or ultrasound. So this is actually funny because These sound like big words, but all they are, and again, I think you heard them before, somebody figured out if you could put a biopsy needle into something, why not try to kill it? So all cryoablation is somebody's trying to freeze the tumor. You're actually literally forming an ice ball in the tumor and freezing it to death. Radiofrequency ablation and microwave sound exactly like what they are. You're burning the tumor. And the last one is this IRE, which is brand new, called nanoknife. And actually, you're actually electrocuting or shocking the tumor with electrical current. So that's some people are starting investigating that with actually the pancreatic ones, but that's still hasn't been proven to work. It's still in the experimental phase. We could do it with different areas and different types of modalities, but I just want to show you very quickly again. We can go through the skin again, do this, and you're forming ice balls here. Here's a case from the liver. Here's a little liver spot. Some of these patients aren't candidates. Some of them might be too sick to go to Dr. Eddinghausen. Some of them might have gone through a big procedure and there's one left. We can try to do this through the skin. So using the CAT scan, here's a big ice ball, and this patient did pretty well. Here's one of the kidney. We do this for the kidneys a lot. This is not really pertaining to this talk, but I just want to show you because it's very common. This is not new technology. This is actually the equivalent of surgical removal of this tumor now. Sorry, this is the kidney. Here's the spine, and here's a tumor right here. And we do this quite often here, and actually the success rate is very high. Here's a needle. Here's 2 with here's 3 going in, and there's a big ice ball around it, and now actually the tumor's dead. So these patients do quite well. This is literally what it looks like. It's literally an ice ball at the end. It looks like a lollipop. Once you freeze it, that's going to freeze around the tumor and cause it to die. Again, I show when it spreads, these things spread. The only reason I'm showing this is because sometimes people don't know what options they have. This guy, again, it was palliative. This guy was very sick. He knew he wouldn't have much longer to live, but he didn't want to be in the hospital. His goal, this is done by my colleague, Dr. Broder, his goal was to get out of the hospital and play his poker game at home. And so he had this big tumor on his tailbone, and he couldn't sit down. So what we did, we actually went in there, froze the tumor. You actually see where the tumor freezing is, where the ice ball is. This guy actually had no pain there, was able to go home, lived a few months, but actually was able to go to his poker game. So it's little things like that sometimes are very important to people, for their quality of life. Here again is what we talk about, the RFA. You put a probe in, you actually burn the tumor. Here's a lesion in the liver. I'm sorry these are coming out so dark over here, or maybe it's just the angle I'm standing at. Here's the liver again, and you see there's a big tumor here. And I'm not sure, I don't remember exactly why. I think this is a solitary tumor. I believe this patient was not a candidate for surgery. So we went in and we did RFA, which is again this heating probe. So you put a probe in, it looks like a biopsy, except it comes out with these tines. Dr. Eddinghausen showed that too, which actually gives us a much bigger surface area for which it gets. You can see these tines in the ultrasound, and this gentleman did very well with this tumor as long as you get the coverage. Last thing we actually even do in the lung here. Here's another patient with RFA of the lung. Just want to touch on that quickly. And the last thing I really want to talk about is this very promising or very good treatment we do called Y90 radioembolization. This treatment, as Dr. Haynes has said, we do it in conjunction with the radiation oncologist. It's a wonderful new treatment, very similar to chemoembolization. Instead of actually injecting chemotherapy into these lesions, what we're actually doing is we're injecting little beads, which are little tiny little spheres, not much bigger than red blood cells. And what they actually do is they go into the liver and they emit radiation. It's called a beta emitter. Where they emit radiation is only about 2 millimeters radius around the spot where they're at. So if you can actually get them into the tumor, they provide lethal doses of radiation without damaging or having much collateral damage. So the beautiful part about this is that the particles are so small. Radioembolization in some ways is a little misnomer because we're actually not really embolizing. We're not stopping the blood flow. We're actually getting these particles in there. It stops a little bit of blood flow, but it's not actually killing the blood vessels, which is good because we know that sometimes these tumors actually grow faster if you stop the blood flow. So the good thing is you're delivering the radiation there. And the best part about it, what we like, and this is what Dr. Haynes was talking about, when we see these patients afterwards, they do quite well. These patients come in twice. They go home the same day, usually 2 to 3 hours later, sometimes 4 hours later. And the most general thing they say is they feel some fatigue that happens a few weeks later. But for the most part, they don't have to stay in house. They have minimal, if any, pain. Most of them don't need any anesthesia when we do the procedure. So it's a wonderful procedure in terms of what we can provide and not being too intrusive or invasive in somebody's lifestyle. And again, the goals we'll talk about in a second. So here's a little animation. Let me just describe again. Here's the body. And we're going to focus in on the liver and where the liver is here. So in this liver, you'll see there's multiple little spots, and they're going to light up here. These are tumors in the liver. And you can see now this patient would not be a candidate, as Dr. Eddinghausen was saying, because they're in multiple different spots. You can't take the entire tumor out. So there's probably too much to actually, in a case like this, might be too much to do even radiation, so this patient might be considered for a Y90. So again, what we're talking about here is that portal vein, this blue one here that's just lining up here, is supplying most of the liver normally. The other little red arteries are supplying the tumor. So what we do is we have to get our tube, or what's called a catheter, into those arteries, and that's the key to this procedure. So what we do is we usually go right into the groin. We put this small little tube up there. The tube will go up into this big vessel called the aorta, and what we do is we find the main vessel. This is the vessel called the celiac artery, and you can see this is where the liver would be, so we find it and put another little smaller tube right towards the liver artery. Once we do that, you can see these little red blood cells are moving. We can inject our little particles. The particles go in and they're directed right at the tumor. Again, if you think about these tumors are growing so fast, they suck up particles or anything you give to them as quick as they can. So they preferentially will suck up these Y90 little spheres much more quickly and much more aggressively than surrounding normal tissue. So that's why, as you can see, here's a very nice, this animation is beautiful, we're showing how these particles will be sucked up by these tumors that sit there, and then they're going to start, and the main key is to get them small enough so that they actually get inside the tumor itself. You want to get them as deep in because they're, again, only a 2 millimeter radius of injection. You can see how small these are. They're 32 microns, which is 4 times the size of a blood vessel, or a red blood cell, sorry. So again, you're showing how they're coming through and they're getting to this area. They stay in the tumor, and again, they're going to radiate over the next few days until they cause that lethal dose. This is the little bubble animation showing that they're causing the radiation. The key to this is to not allow these particles to go into normal tissue because they can obviously cause much more damage there too. So if you can keep them in here, it's a wonderful treatment because no matter how many lesions or spots there are on the liver, most of them can take it up. Again, this is not a cure. For some patients, it could be a cure, but for majority of patients, this is to keep these tumors from growing more, from going in size. It's a palliative treatment. It's allowing people to live longer and live a better quality of life, as opposed to just allowing these tumors to grow uncontrollably with nothing else to do. I'll just keep on going here. Let me just show you a case that we did here. Here's a patient. Obviously, you can see very clearly multiple liver spots all over the liver. Again, this is the stomach, this is the spleen, but you can see the liver is sort of filled with these lesions. Here, if you're lighting up, you see what the portal vein looks like here. So this is, this is a patient who didn't have too many options. So what we did is we went after, we decided Y90, radioembolization would be the best thing. So here's a PET scan for the same patient. You sort of see where the head, the arms are of the patient's body, and you can see those giant liver spots again in the PET scan. PET scan shows these very, very well. The Y90 procedure is a 2-day process. The first day we come in, we do what's called a prep angio. We do a quick angiography, and I'll show you that in a second, what that means. We actually close off blood vessels that we need to close off, and I'll explain why. And then we do a test run. The test run is so that to make sure that we don't inject these particles in the wrong part of the body. And I'll explain that in a second. And then part 2, you come back, is the easy part. Dr. Haynes generally comes down, we meet, and we put the catheter in there, and we inject these particles. It's quite easy to do the second part. So why do we have to do this test run the first day? So the big issue is these particles, if you're going to inject them, you want them to go, again, right into the liver, right to the tumor, sit there, they radiate the tumor. Problem is, there's so many blood vessels that are interconnected. These can go right through, right to the heart, sit into the lung. When they sit in the lung, they can actually cause things like pulmonary fibrosis or a lot of damage to the lung. So if these get into the lung, it's a huge issue. The other issue is if they go right through normal blood vessels or right to the stomach or the other parts of the bowel, they can cause ulcers and bleeding. So you have to be very, very careful where these go. How can we ensure that they're going to the right spot? This is called an angiogram. This is the same thing. This is my tube or the catheter going into the liver artery. Again, the liver is here. This is going to the liver artery. This is all the blood vessels feeding the tumor. And the tumor is a little harder to see here. This is a blood vessel called the GDA or the gastroduodenal artery. This one comes around and goes right to the stomach. If we inject it here and let particles go through here, they'll go right into the stomach. This patient will come back probably in a few weeks, bleeding, having ulcers, having horrible pain. So what we do, we know this artery has, it's like a, well, let me show you what we did. What we do here is we block off that artery. We use little things called coils. We block it off. Now you see no flow going this way. People always ask, how can you take out an artery and not cause any problems? It's like I would say it's like a accident on the highway. For a brief while is an issue, but then the blood flow detours right around and goes to the other areas. It just doesn't go directly to the stomach. So now we're going to put our little catheter up higher. We'll go back. Put your catheter up higher, and we actually start injecting. However, again, you don't know at this point if you can inject the proper way. So what do we do? At this point, the beautiful thing, we have these other particles in our department which actually mimic, they're the same size, but they're not radioactive. They're the same exact size as Y90. What we do is we inject it from there, and we go do a scan. You can see in the scan, this looks like a blob, but in actuality, this is actually the liver, and it's all the particles are in the liver. So this is our test run. So you can see in this test run again, here, nothing's in the lungs, nothing's in the stomach. That's how we know that we actually did the safe thing. So we do this test run on the first day. Here's a patient we did way back when, 2009, when first starting this. And you can see here, the lungs clearly took up a lot of this Y90. This patient, we still did it, but we had to reduce the dose a lot because otherwise we could have caused a problem to the lungs. That's why we do it, the test run on day 1. Day 2, the Y90 part is very easy. This is the part we actually inject the particles. It's a huge contraption like this. And you can see here, unlike the other picture where all the blood vessels were gone, you see the little blood vessels going in. We're injecting into the tumor. You can't really see that it's getting in there, but we know that it's getting in the right spot. And these patients do very well at the end. So last thing, just summarize what the Y90. It's a wonderful new treatment. It's great to prolong, the goals here, we're trying to prolong survival, slow down or stop the tumor growth. You act as a bridge to liver transplant for some patients, or you try to downgrade it so that they can actually become a surgical candidate. And for things like neuroendocrine we were talking about before, sometimes they really help the symptoms. So it's a wonderful new treatment. And again, we're doing, we're trying to do quite a few of them here. So again, thank you. Any questions? I'll be happy to answer anything here. Yes? Okay, so sorry, the question was, how do we block off the artery during that Y90 procedure? I'll just go back a little bit. So in this case, this artery that we're trying to block off, we do it right there. We actually take a little catheter, we put it in there, and we put something called a coil in. The coil is a long thing that looks like a piece of hair, but actually it's made of nitinol or steel. We actually put it in there, and it starts coiling in and blocks up the vessel. So we do it right there at that time. If you can get most of the tumor, and the tumor is fine. If you're asking if there's complications in surgery, definitely. I mean, these are very dangerous surgeries, so there could be complications. But if you get most of the tumor, it's a curative. What they're going for is a cure with surgery. So that's why we always say if surgery is an option to get all of the tumor, you always want to start with that. If not, these are more of the options for if it's already spread too far to do those things. So otherwise, you want to go with the radiation or the surgery first. All right. Any other questions? Yes, ma'am. Good question. This is a question that people, Y90 versus chemoembolization versus chemotherapy. For the most part, chemotherapy has a lot more options, the different drugs that we can deliver. We can't deliver every single drug right through here. So we deliver very specific drugs. Chemotherapy also attacks other parts of the body. We only go for parts of the liver. So if it's the liver, and it's a drug that we can deliver, obviously it's generally something that we try to do because it's better for us to deliver. If it's another part of the body or another drug that might be better, chemotherapy is usually a better option. Y90 and chemoembolization, there's big debates right now everywhere because they're both new. There's no good study to prove one's better than the other. So you'll see if you go to places, some hospitals will use chemoembolization, some places will use Y90. Most places are using both, and we use both here. We've just seen that a lot of the patients, they just tolerate this better. I'll tell you, a lot of patients will say, I don't want to stay in the hospital for a day or two. So that's a big decision to say, I'm coming in for a procedure and I go home 4 hours later twice. And a lot of people say, I don't want that, I don't want to be sick for weeks or a couple of days. So to have that just fatigue, and it could be quite amount of, substantial fatigue. I don't mean, I'm not downplaying this, just you're tired. You have a really bad fatigue. But take fatigue as opposed to a lot of abdominal pain and a lot of nausea and vomiting, it's significant for patients. So the patients tolerate these very, very well, and we've seen that they've done very well. We're tend to favoring this in our hospital right now.
So what about
Right, and so this is actually, the first FDA approval was for this, for colorectal mets to the liver. This is specifically made for that, and that's why they've actually responded quite well to that. and that's why we are doing that for this. We do use both. We're still all doing chemoembolization, but most of the patients are getting this because it's responding so well. The indications are expanding quite quickly for this. So it's used to be just for things like colorectal mets to the liver, and now it's for a lot more. It's expanding to a lot more. So does somebody else have a question? Yes, sir.
If you have the chemoembolization,
yes.
And how long before you can measure the results of that?
Usually it takes a few months. Tumors don't just go away or stop. You measure by how much contrast it takes up and how much it shrinks. So usually for most people, for most things, you want to wait at least 3 months to see.
So assuming that you're only having a quarter of the liver treated,
yeah.
On the initial, you're saying that it's months before you can measure any results?
Quarter liver for which one?
Well, I was told that in the chemoembolization that they inject just enough to treat, say, about a quarter of the liver area.
So for chemoembolization, we'll generally go as far into the tumor as possible and deliver it right into the tumor. If there's multiple tumors, we'll actually hit multiple spots. For the Y90, what we'll actually do is we'll treat the right lobe one day, usually have the patient come back in 1 week to 1 month, within a couple of weeks, and just treat the left side. So either way, we're going to treat everything. It's just for both of them, you cannot treat everything on the same day, or you generally should not treat everything the same day because it's too much at one time for the liver to handle. But yeah, otherwise, you're treating everything. You don't wait to see the response. So for Y90, if we were treating somebody today, we'd just schedule them for an appointment. We'd treat the right lobe today, bring them back in 3 weeks, treat the left lobe. You wouldn't do any more scanning to see that.
So let's say that the chemoembolization didn't work.
Yeah.
Are you still a candidate for the Y90?
Great question. Absolutely, yeah. We have patients who've had chemoembolization, and if they failed, you can then go to Y90, and vice versa. And vice versa, yeah. So you can do both. You can't do Y90. You have to generally wait at least a year for Y90, and even after that, you can't do it too much because you give too much cumulative dose to the liver to keep on going. But chemoembolization you can do multiple times. So a lot of people right now, what the strategy is, because this seems to be working better and better tolerated, you start with Y90, and if they need or have some issue, you can go to the chemoembolization and do that afterwards.
So if you're a candidate for chemo, you're a candidate for radiation too?
For the most part, yeah. A lot of people are interchangeable, yes. Yes. There are a few exceptions, but yeah, for the most part, yes. So, more questions? New? Chemoembolization has been around for probably about 25, 30 years, so it probably became popular in the early 90s. Y90 Surspheres got FDA approved in 2002, I believe. So it's been about 10, 11 years that people have been doing it. So this is most places are doing this now too. This, 5, 6, 7 years ago, this was a little more exclusive, but most places, well, not most places, a lot of places are doing it, doing Y90 now too. Any more questions? Yes, sir?
Yes, due to all this cannabis insurance policy, how much is this?
Well, this should be covered by insurance. No, absolutely, yeah. All the treatments here, everything you're talking about here from, actually, I shouldn't speak for them. For the treatments here, these are covered by insurance. Y90, I actually know the company we work with the Surspheres. They have people at their company. We actually call them. They do a great job helping the patient make sure everything's covered, which is actually a great part of the service. So it's, yeah, this should be covered by insurance. Any other questions? Yeah.
The Y90 delivery, the way it's delivered,
Yes.
the catheter,
Yes.
how do you navigate through the artery?
Great question. We do, it's just, obviously it's a lot of practice and training from getting into the proper arteries. It's knowing the anatomy. Once you can get into this way, we know that we're going right towards the liver. But for the most part, when I do the procedure, I always do a CAT scan beforehand. So I already know the anatomy, because some people have variant anatomy switched around, things like that. We'll already know the anatomy beforehand, because we'll actually get a CAT scan, what's called a prep CAT scan beforehand. So I'll know all the anatomy, exactly where we're going, mapped out before we even start. No. Everything's going through. Sorry, a tiny nick in the groin. Sorry. So what we're doing is not a surgery. It's called a catheterization. So it's just a tiny nick in the artery. We use a little lidocaine, give you a little bit of medication. People are generally awake. It's called conscious sedation. We put the tube up and guide the tube with contrast into the proper artery, and then go from there. Any other questions? All right, great. Thank you very much. Is that what you saw? Okay.